Okay, I think probably our last speaker for the morning session, or the first morning session, is Dr. Gilbert Tang. He's the surgical director of the structural heart program at the Mount Sinai Health System in New York. Welcome, Dr. Tang.
Thanks very much. So I'm going to talk about the transcatheter approaches to the tricuspid valve. Here are my disclosures. I am a site PI of the Triluminary tricuspid valve repair feasibility study with Abbott. We already went through the guidelines in the stages of TR, and certainly we have been having some problems treating the severe TR because they haven't been addressed recently. And if you look at the lead-related tricuspid regurgitation management, you can see that certainly surgery is an option, but no mention of tricuspid repair from a transcatheter standpoint. And if you look at people who had mitral clip repair with significant TR, you can see that if they have severe TR, they don't do very well. About 38.5%, 40% die at 1 year. So certainly, this is unmet clinical need. So as we previous speaker mentioned, the principal tricuspid repair is to ensure the leaflet coaptation mobility. You want to stabilize the annulus, and you want to avoid conduction injury. You can see there's some of the tricuspid repair techniques surgically done. Some of them are historical. But if you compare these repair techniques, they're actually not dissimilar to the one that are being developed right now for transcatheter approaches. You have direct suture annuloplasty. You have, such as the Triline device. You have direct ring annuloplasty, such as cardiomagnetic millipede. You have leaflet devices, such as edge-to-edge, the clip or the Pascal or cinch, or you can have even valve replacement. However, there are a lot of challenges associated with designing these transcatheter devices for TR, and this is just a short list of them. There are other these design challenges too, not just the device itself, but the clinical trial. First of all, this is a very heterogeneous population. You have the primary TR patients, and they have the secondary TR patients. Beyond the mitral valve, the tricuspid is actually relatively difficult to image, at least from what we have right now. So quality imaging is a prerequisite, and depending on what device you use, the imaging requirement is actually different. And also the anatomical criteria that will fit certain devices also vary. And finally, how do you define these clinical endpoints? You already heard about the COAP trial and other functional MR trial. Well, this is now functional TR with a mix of patients. How do we actually achieve a clinical endpoint that can, for example, the FDA can use to approve the device? And of course, if you've seen before, if you have significant residual TR, it's still bad for you. So when should we consider transcatheter repair over surgical repair in these patients? Well, first of all, there are no devices approved in the United States right now. They're all under various stages of clinical trial. Typically, these patients are high or extreme risk for primary or reoperate surgery. They also have to have favorable tricuspid anatomy, and you actually have good TE imaging is required for these patients to be able to implant a device. Now, having said that, the RV lead in the presence of pacemaker ICD is not a contraindication, but you do need to have quality imaging to be able to see what you're doing. And finally, we do avoid trying an end-stage patient, kind of like the cohort C patients. In TAVR, we do the same thing in tricuspid patients. Now, we talked about imaging for transcatheter tricuspid valve intervention, so this is kind of a list looking at what to do before the procedure, during the procedure, and after the procedure. So typically, echo is the primary modality, although CT is now increasingly important. Look at some of the devices that require anatomical criteria to be able to screen for the procedure. In terms of intraprocedurally, certainly the mainstay is TEE, 2D and 3D. ICE is now coming to be more popular, and I think better technologies will allow that to become a complementary device to TEE. Of course, transthoracic echo is also another adjunctive modality as well. However, it is quite operator dependent. And finally, post-procedural assessment, we need to, during the case, be able to assess it accurately on 2D and 3D TEE. Now, besides echo, we also use fluoroscopy. This is just some of the basic views of tricuspid valve on fluoro. You can see here, this is a nice image showing a tricuspid valve prosthesis with sapien valve inside. And you can see that on the RAO view, essentially, anterior septal, posterior septal are roughly located this way. And you can imagine a pigtail can be placed in the aortic root. If you look at the LAO view, where you're now actually looking at the valve directly from your feet, you can see this is roughly where the locations are where the leaflets commissures would be. This is a really nice JACC review looking at the tricuspid imaging, so I encourage you to read it and take a look and see how the image of tricuspid valve, because a lot of these patients, before even considered for transcatheter therapy, they need to have good imaging. So we actually try to simulate the actual procedure, what we're looking for in the echo lab to make sure we have good imaging before we actually consider screening these patients. CT, as I mentioned, is relatively important now, especially some of the repair device, like the annuloplasty device. The reason is, if you see here, the right corner is running right along the AV groove. If you have an annuloplasty device, percutaneously, you can risk injuring the coronary. And you can see here, this is an example where you have patient have surgical tricuspid repair. You can see the annuloplasty ring here. You can see there was a kink, probably a suture placed too deeply. And you can see here, this needs to be urgently addressed, usually probably percutaneously. You usually take the patient to the cath lab, and stenting is should resolve. This is the first human timeline of what transcatheter tricuspid therapies have been like. You can see here, actually, the first implant was actually a replacement device more than almost 8 years ago. And you can see here steadily there have been a string of devices coming down the pipeline of different stages of the clinical trial. In terms of how to get to the tricuspid valve, the most straightforward is probably transfemoral from below, which is a venous stick. You can also go from the jugular. You can go directly transatrially, and rarely we go transapically. The targets are typically surrounding anatomically the tricuspid leaflets, the annulus, or even the IVC. So I'll describe 2 to 3 technologies to you in the interest of time. The first one is the Abbott TriClip system, which is edge repair. It's essentially, at least the current generation, same as the MITRAL clip, but going forward in terms of the next generation, it will be available with the longer clip arm like the XTR or NTR being used commercially right now in the mitral position. This is the Triluminary tricuspid clip design. It's a single arm, multi-center feasibility study involving both Europe and the US. There are 4 sites in the US, and Mount Sinai is one of the sites. And now the FDA has expanded up to 35 patients treated in the United States as part of this feasibility study. The trial actually has just wrapped up enrollment, and we'll expect the 30-day data to be coming soon after core lab analysis. The follow-up is 3 years. The primary endpoint is TR reduction because it's a feasibility study, and the secondary endpoint being cardiac mortality. Here's the inclusion criteria. You do have to have moderate or greater TR by core lab adjudication. The heart team has to deem the patient to be appropriate for transcatheter intervention. You cannot address the mitral valve within 30 days if the patient has concomitant significant MR, and you have the suitable tricuspid anatomy. Exclusion, this is the feasibility study, so it's quite strange, and you can see if you have concomitant MR, you have to fix that first, surgically or transcatheter. Anyone with significant pulmonary hypertension is excluded. If you have leaflet surgery, you exclude it. This is not an exclusion in terms of the lead, as I mentioned before, as long as it doesn't interfere with the procedure. We have not treated patients over 9 years old and anyone with chronic dialysis. So this is our first case treated at Mount Sinai, 72-year-old female, certainly quite a few comorbidities, myelofibrosis, polycythemia, restricted lung disease, and HOMO2. She had permanent pacemaker or AFib, and also moderate pulmonary hypertension. So we actually clipped her over a year ago for her primary MR, and we actually closed her ASD because she acutely desatted after we finished the case. And of course, despite fixing the MR, her TR persisted. You can see here she's on quite a significant amount of diuretics and medical therapy already. So here's the baseline T. You can see here, just to orient everyone in terms of the anatomy here. This is the right ventricle, right atrium. This is the anterior leaflet. The posterior is over there. You can see this is the one without color. This is another view here. This is what we call a transgastric view. This is one of the very important views for the echo in terms of guiding the tricuspid clip therapy, because on this view, you can actually see all 3 leaflets aligned, and you'll be able to orient the clip, just similar to what you do in fluoroscopy or in mitral valve, where you do your 3D on false view. So 3D is really difficult to do on tricuspid valve because the leaflets are thinner, and of course the tricuspid is away from the esophagus, so we rely on this view a lot. You can see this is a right ventricle, right atrial view, showing a significant amount of TR. You can also see where the pacemaker lead as well. So this is one of the grasping view here, which is a 140 or 180 view. You can see here is almost a reverse 4-chamber, showing the septal anterior leaflet. This is the most common target we use for tricuspid clip because it's, the trajectory is the most favorable. And you do need to check for leaflet insertion because, as we talked about, the leaflets of the tricuspid valve are thinner and more delicate. So you really need to make sure you won't risk a leaflet detachment. So we use fluoro in complementary to the echo as well. You can see here, if you look at the LAO view, in this particular patient with an ASD occluder to kind of reference, stress of reference, we can see here roughly the anterior septal would be right here. On the RAO view would be right here like this. And then on the second clip, we actually went after anterior posterior here because the lead is kind of in the way for the posterior septal. And you can see here, this is the orientation, the trajectory that we aim for. Typically in the RAO view for the anterior posterior, the clip will be facing you, and the other view will be actually, the clip arms will be in parallel to you. So you can see this is why the transcuspid view is important, because you can orient the clip very well perpendicular to the grasp plane, and you can explain that to make sure you can see the clip properly, and you can see you can close in the clip on the view. So this is the end of the case. You can see this anterior septal, this is the anterior posterior, that's the mitral clip from before, and the ASD occluder. So this is pre-implant. You can see here there's a significant amount of TR in this view. Certainly, because the limitation of the lead, you're not able to completely eliminate the TR. We actually thought about, before enrolling this patient, to extract the lead and put a micro device in, but because of our comorbidities and the risks involved, we decided just to screen her directly for the trial. And this is another view here. You can see here, at least visually and quantitatively, the TR has improved. This is the echo of 30 days. You can see both clips are in place. One of the main concerns we have is make sure there's no late detachment, because the leaflets are flimsier than the mitral leaflets. This is an annuloplasty device. It's a percutaneous annuloplasty cardioband. It's bought by Edwards. It's the tricuspid position. You can see here, this is the initial pre-cinching position. You can see after cinching, you can see a dramatic annular reduction on fluoroscopy and also TR reduction as well. And this has been CE mark approved now based on this trial, which is 30 patients, a feasibility study, look at moderate severe TR. And you can see here, unlike the edge repair device, this one has a sustained annular dimension of 18 patients at 6 months so far, which is promising. And also in terms of the echocardiographic parameters for TR, also has significant improvement as well. And finally, going to replacement, this is the device currently being in feasibility study both in Europe and the US. You can see this is a very large device because these patients typically very large tricuspid valve. It's a transjugular, transatrial approach. You can see here 40 French systems, certainly very large, and about 27 cases so far with 5 mortalities, and 3 out of 22 require pacemakers. I'm going to switch gears a little bit. What can we do in the meantime for some of these patients with previous tricuspid replacement? So this is a registry that was looking at patient putting in sapien valve in the tricuspid position with previous prosthetic valve. And you can see here, in terms of the survival, you can see if you are older and have worsening NYHA class pre-op, you certainly don't do as well, and probably do not just because of TR, but because of the underlying RV dysfunction. So this is a case, for example, a 71-year-old with carcinoid syndrome with previous actually double valve replacement and an RVOT enlargement, now with coming back with valve prosthetic, TR, and stenosis. So you can see here the gradient across the tricuspid valve was 12 with a severe TR. We do CT sizing for these cases in confirmation with the operative report and the patient's ID card. You can see here this is relatively a St. Jude epic, 25 millimeters. So you can actually use the valve-in-valve mitral app, which is the same as the tricuspid app, and you can size accordingly. So you can see here, one of the challenges of this case is that the St. Jude epic valve, you can't really see where the annulus is. You really have to look carefully during the valve implantation to be able to place it accurately. And just like the mitral valve-in-valve, we typically place in the same position around at least 80 to 20, 80% ventricular to avoid late migration, even though this is the venous side, so less systolic force. So this is the pre-implant, this is the pro-implant, certainly with really dramatic improvement. These patients do very well post-op. They typically go home the next day or the day after, just like a mitral clip device, because it's totally percutaneous, doesn't even require transeptal puncture. However, if you look at valve in ring in these patients, they don't do as well. You can see this is a younger group of patients, 45 years of age, majority of actually congenital repairs, and you can see here 50% already have a pacemaker lead. And if you see the outcomes, you can see 10% of them, this is small series obviously, need a second valve, and also if you look at procedural complications, not benign. And this is a really sobering figure. You can see here they tried multiple different rings, and if you look at the data, 9 out of 20 still left with moderate severe paravalvular leak. So certainly, valving ring in this particular position certainly still fraught with challenges. But I think what we draw your attention is actually really which transcatheter valve therapies are appropriate for which patients. I think we really need to look at how advanced stage their heart failure is and the right ventricular dysfunction is, just like similar to the left side. You can see if they are early in their pathophysiology, you can see a multiple device should be able to address this issue. But as you get more and more advanced, you have to think about either they have to be palliated, or you might be having something like a replacement, or you might have something that just basically plug the regurgitant opening to reduce the TR, but you really don't address the underlying right ventricular dysfunction. So in summary, I think unrelated severe TR carries a poor prognosis we have seen before. Tricuspid repair, as you've seen in previous presentation with remodeling annuloplasty, is currently a gold standard in surgery and does very well. Certainly transcatheter therapy right now is still in infancy, but early results are promising. But I think the heart team approach in early evaluation and management in this high-risk population really maximize the opportunity to offer the entire spectrum of therapies to these patients similar to mitral valve disease. Thanks very much for your attention.
Dr. Tang, I'll get you to stay up there for one. Dr. Tang, I'll get you back up there for a question. We'll take a minute. We're exactly on time. We have a minute or two for questions. So if anybody has one, we have microphones at the side. It's a good opportunity to sort of, whatever you've been thinking about for the last hour or two, now's a chance to get the speakers to respond. Quick question for you. So the transcatheter tricuspid valve replacement in a native tricuspid valve, in theory, it's probably easier than the mitral because you don't have the ejection forces, it's low pressure, probably more tolerant of PVL because you're not going to probably have hemolysis under low pressure, and you don't have really the concerns of RVOT obstruction. So why is it taking so long, and why is it so hard?
I think it's how big the tricuspid annulus is. If you look at, Navigate's the first one out right now, it's like 50 millimeter valve. I mean, most of them are done surgically because it's like trying to cannulate the jugular vein with a 50 French device. It's massive. So I think you have to deal with these patients. Remember, high CVP pressure. They don't tolerate bleeding very well during the procedure because of RV dysfunction. So I think that's what is taking so long. And we don't know what the durability in terms of anticoagulation for thrombosis, right? Because it's the lower side of pressure. I think in terms of the repair device being percutaneously transfemoral is probably the more elegant way to go about doing it. I expect some kind of annuloplasty and edge-to-edge combination therapy is going to be doing fine. That's probably, I suspect, why it's taking so long for the replacement option to kind of get up there.
So you think 5 years from now, femoral replacement or repair technologies will outpace replacements?
I just think first of all, you have to repair more tricuspid valve surgically, so you have to go back in and fix these transcatheter. I think that's really the first message out there. But if you do, I think still just like the functional MR patient, treat them medically, as aggressive as you can. If you can catch them early enough before they have kind of end-stage RV dysfunction, I think that's where the sweet spot will be.
Right. Okay, well then I think we'll take a 15-minute break. We'll see you back in a few minutes.